Hi everyone, I'm Sir Yulai, and for this slide sets, we will be discussing dengue. Dengue is the fastest spreading vector-borne disease in the world, endemic in 100 countries. In this throwback slide, we review that a vector is an animal or flying or crawling insect that serves as an intermediate means of transporting the infectious agent. Dengue is defined as an acute febrile illness of 2 to 7 days duration, sometimes biphasic, with no identifiable focus of infection. A biphasic fever is a fever which may abate after a day or two, only to rise again. This biphasic fever is also known as the saddleback fever, and it has two peaks. Dengue is caused by the dengue virus of the family Flaviviridae, and it has four serotypes. These four serotypes are dengue virus 1, dengue virus 2, dengue virus 3, and dengue virus 4. It is important to note that immunity to one serotype does not confer immunity to the others. So technically, one can have dengue four times. The Southeastern Asian dengue virus 2 variants have more potential to cause severe dengue than do other variants. Usually, the first infection with one of the four serotypes is non-severe or asymptomatic, while second infection with one of other serotypes may cause severe dengue. The dengue virus is transmitted by a bite of female Aedes aegypti mosquito. This is so because only female mosquitoes bite people and animals to get a blood meal. Female mosquitoes need a blood meal to produce eggs. The primary vector is Aedes aegypti, and secondary vector would be the Aedes albopictus. These mosquitoes breed near human habitation using relatively fresh water from sources such as water jugs, vases, discarded containers, coconut husks, and old tires. Observe that these are stagnant water. DOH is actually advocating mag 4 o'clock habit wherein people are advised to search and destroy for these breeding grounds. When the female Aedes aegypti mosquito bites a person infected with dengue, the dengue virus replicates in the mosquito for 8 to 12 days and remains infective for life. Take note as well that these mosquitoes are day biting. Dengue, letter D, for day biting. The incubation period is 2 to 7 days. Applying our learning in the introduction, it means to say that it will take 2 to 7 days before a person will develop symptoms when bitten by a mosquito carrying the dengue virus. The classic symptom is sudden onset of fever, again possibly characterized as biphasic or saddleback, headache, retroorbital pain, and back pain along with severe myalgia. Dengue fever used to be called break bone fever, which might give you an idea of the severe bone and muscle pain it sometimes can cause. Often, a transient macular rash appears on the first day, as do adenopathy, palatal vesicles, and scleral injection. The characteristic rash of dengue is transient, macular, generalized rash that blanches under pressure, seen during the first 24 to 48 hours of fever. 1 to 2 days after the effervescence, a generalized maculopapular rash appears which spares the palms and soles. This disappears in 1 to 5 days and may disquamate. This is known as the Hermann rash. This diffuse erythematous maculopapular rash, described as islands of white in a sea of red, develops 3 to 6 days after onset of fever and coincides with defervescence. The erythematous rash, or the red in appearance, is due to an increase in capillary permeability and fluid leakage as a result of damaged capillary walls from an immune reaction secondary to the infection. The island of white described in the rash, or the spots of white that are not erythematous, are areas where there is more edema than the surrounding area as a result of a greater increase in fluid leakage. The course of dengue fever is usually divided into three phases: the febrile phase, the critical phase, and the recovery phase. During the febrile phase, which usually lasts 2 to 7 days, symptoms include fever, facial flushing or skin erythema, myalgia or arthralgia, retroorbital eye pain, photophobia, rubelliform exanthema, headache, sore throat, conjunctival injection, and anorexia, nausea, and vomiting. For the visual learners, here is an illustration from the Centers for Disease Control summarizing the symptoms of dengue. Given the non-specificity of the symptoms, it can be difficult to distinguish dengue clinically from non-dengue febrile diseases in the early febrile phase. A positive Tornika test in this phase indicates an increased probability of dengue. So how do we do a Tornika test? Take the patient's blood pressure and record it. For example, 100 over 70. Inflate the cuff to a point midway between the systolic and diastolic blood pressure and maintain for 5 minutes. For example, with a BP of 100 over 70, that would be 100 plus 70 divided by 2, that would be 85 millimeter mercury. So in this case, we are going to maintain the blood pressure cuff at 85 millimeter mercury for 5 minutes. Count the petechia below the antecubital fossa, seen in this slide. A positive test is 10 or more petechia per 1 square inch. PE findings can range from the mild to the severe. Mild hemorrhagic manifestations include petechia and mucosal membrane bleeding and easy bruising. Massive vaginal bleeding may occur in women of childbearing age, and GI bleeding may also occur, although it is not common. Another PE finding would be liver that may be enlarged and tender after a few days of fever. A progressive decrease in total white cell count is the earliest abnormality in the full CBC. Significant viremia during early febrile phase is also seen. As you can see in this slide, viremia is significant during the early febrile phase. I would also like to comment that although we often associate dengue with a decrease in the platelet, it is actually a decrease in the WBC that is the earliest abnormality seen in CBC. Because of the febrile episodes, the patient is prone to dehydration at this time. Defervescence occurs between 3 to 7 days of illness. Defervescence is known as the period in which the body temperature or the fever drops to almost normal. Those who will improve after defervescence will be categorized as dengue without warning signs, while those who will deteriorate will manifest warning signs and will be categorized as dengue with warning signs, or some may progress to severe dengue. When warning signs occur, severe dengue may follow near the time of defervescence, which usually happens between 24 to 48 hours. Paraphrased, possible outcomes during the transition from the febrile to afebrile phase would be 1. Patients without an increase in capillary permeability will improve without going through the critical phase, or 2. Patients with increased capillary permeability may manifest with the warning signs, mostly as a result of plasma leakage. In short, the warning signs occur mostly as a result of plasma leakage. This plasma leakage is preceded by progressive leukopenia, decreased platelet, and increasing hematocrit. Correlate it with the boxed portion in the graph. I usually remember these changes as what the hell, W for WBC, T for thrombocyte, which both decrease, and H hematocrit, which increases. Warning signs include abdominal pain or tenderness, mucosal bleed, persistent vomiting, clinical fluid collection such as ascites or pleural effusion, increase in hematocrit concurrent with rapid decrease in platelet count, lethargy or restlessness, and liver enlargement more than 2 centimeters. Signs of severe dengue include severe plasma leakage leading to shock and fluid accumulation with respiratory distress, or severe bleeding, or severe organ involvement, usually indicated by an ALT or AST more than 1,000, or impaired consciousness and involvement of the heart and other organs. A classic way to remember this is as classic as the PBO or the Pinoy Box Office. It means P for plasma leakage, O for bleeding, and O for organ involvement. Clinical findings in shock include hypotension, narrow pulse pressure less than 20 millimeter mercury, subnormal body temperature, weak pulse, tachycardia, tachypnea, restlessness and combativeness, and prolonged capillary refill time. The vital sign changes in shock is a must know because it is not only seen in dengue, but it is seen in a wide variety of cases. Of course, nothing beats understanding physiology and understanding the mechanisms why these vital sign changes occur. But if you have difficulty understanding the concept, you could actually use this memory aid. In shock, bababa lahat ng vital signs na may letter B, such as in BP for blood pressure and BT for temperature. And magra-rise ang mga vital signs that has R, as in RR and heart rate. Severe hemorrhage caused the hematocrit to decrease in severe shock. Instead of the leukopenia usually seen during this phase of dengue, the total WBC may increase as a stress response in patients with severe bleeding. In addition, the coagulation parameters may be altered. If the patient survives the 24 to 48-hour critical phase, what happens next? A gradual reabsorption of extravascular compartment fluid takes place in the following 48 to 72 hours. General well-being improves, appetite returns, gastrointestinal symptoms abate, hemodynamic status stabilizes, and diuresis ensues. During the recovery phase, the rash of Isle of Wight in the Sea of Red appears, while the patient may complain of generalized pruritus. Bradycardia may be seen. The hematocrit stabilizes or may be lower due to the dilutional effect of reabsorbed fluid. WBC count usually starts to rise soon after the effervescence, but the recovery of platelet count is typically later than that of WBC. Because of the reabsorption of fluid from the extravascular space, the following complications can occur. Respiratory distress from massive pleural effusion and ascites will occur at any time if excessive intravenous fluids have been administered. During the critical and or recovery phases, excessive fluid therapy is associated with pulmonary edema or congestive heart failure. For the diagnostics, NS1 may be requested between 1 to 5 days of illness. It is used to detect dengue virus antigen during the early phase of acute dengue infection. NS1 is best used during the first 5 days of illness because after day 5, dengue antigens disappear. Dengue IgM and IgG may be requested beyond 5 days of illness. It is used to detect dengue antibodies during acute late stage of dengue or to determine previous infection. Complete blood count or CBC is routinely used in hospitals as a standard dengue diagnostic test. Look for trends for decreasing WBC, decreasing platelet, and increasing hematocrit. PCR is one of the gold standard laboratory tests to confirm dengue virus. It is a molecular-based confirmatory test, but is available only in dengue subnational and national reference laboratories. The Tornika test is also known as the Rumpel-Lid capillary fragility test. It is the least sensitive of all tests. This slide presents the classification of dengue fever according to severity. For grade 1, the patient has fever, hemorrhagic manifestations such as positive tourniquet test, and evidence of plasma leakage. In grade 2, grade 1 manifestations plus spontaneous bleeding, epistaxis, GI, and cutaneous bleeding. For grade 3, grade 2 manifestations plus evidence of circulatory failure, and in grade 4, grade 3 manifestations plus profound shock with undetectable blood pressure and pulse. In hospitals, you might see patients admitted as dengue without warning sign, dengue with warning sign, or severe dengue. We have already previously discussed the warning signs and the manifestations of severe dengue. The main management of dengue fever is supportive therapy. Antipyretic is given in the form of paracetamol. Ibuprofen and NSAIDs are generally avoided. Advise patient to increase fluid intake and monitor the input and output. A patient must be able to pass urine at least once every 6 hours. Monitoring of hematocrit and platelet counts are also done, as well as monitoring of complications. Fluid therapy is critical, and the preferred IV fluids are isotonic fluids. These fluids are adjusted based on hematocrit determination, clinical status, and the urine output of patient. Remember that the adequate urine output is defined as a 0.5 cc or 0.5 ml per kilogram per hour in adolescent and adult and 1 cc per kilogram per hour in children. These fluids are tapered off after the critical phase. How about blood transfusion? Prophylactic transfusion is not recommended. Whole blood or packed RBC transfusion is indicated for profuse bleeding or clinical deterioration that does not respond to fluid resuscitation. FFP or fresh frozen plasma and cryoprecipitate are indicated for bleeding that does not respond to whole blood or packed RBC transfusion or in cases of DIC or disseminated intravascular coagulation. Platelet transfusion is indicated if the platelet is less than or equal to 10,000 with bleeding. Additional nursing care includes avoidance of intramuscular injections, avoiding NSAIDs, and monitoring of complications. Of course, prevention is better than cure. So we must practice the 4S in dengue prevention and control. First S, search and destroy mosquito breeding sites, which we have discussed earlier. Second S, self-protection measures like wearing long pants and long-sleeved shirts and daily use of mosquito repellent. Third S, say no to indiscriminate fogging. Support fogging or spraying only in hotspot areas where increase in cases is registered for 2 consecutive weeks to prevent an impending outbreak. And for the last S, seek early consultation. So do we have a vaccine for dengue? We actually have a vaccine, and that is Dengvaxia. The Centers for Disease Control said that in the US, the Dengvaxia vaccine will be available starting in 2022 for use in children 9 through 16 with laboratory confirmed evidence of a previous dengue virus infection and living in areas where dengue is common. In the Philippines, the Department of Health puts dengue immunization on hold after new findings from Sanofi Pasteur. For those who were not previously infected by the dengue virus, the analysis found that vaccination led to a benefit in preventing severe illness for at least 30 months. In the longer term, severe cases may occur following a subsequent dengue infection among those who were not previously infected. That is why, going back to the CDC recommendation, it is for use only in children 9 through 16 with laboratory confirmed evidence of a previous dengue virus infection. So that's it for our discussion for dengue. Pause this video, gather your thoughts, and when you are ready, let us have a practice test. Which one is not true regarding dengue? A. Reinfection with a different serotype is possible. B. It is caused by a Flaviviridae which has 4 serotypes. C. It is transmitted by a night-biting Aedes mosquito. And D. The incubation period is 2 to 7 days. You have 5 seconds. If you answered C, you are correct. It is transmitted by a day-biting Aedes mosquito. Which is not a warning sign of dengue? A. Myalgia. B. Persistent vomiting. C. Mucosal bleeding. D. Abdominal pain. You have 5 seconds. And the correct answer is A. Myalgia. Which is not included in the management of dengue? A. Intravenous fluid. B. NSAIDs. C. Paracetamol. D. None of the above. You have 5 seconds. The answer is B. NSAIDs because of the risk of bleeding. Which finding is not consistent with a patient in shock? A. Bradycardia. B. Prolonged CRT. C. Hypothermia. Or D. Narrow pulse pressure. You have 5 seconds. If you answered A. Bradycardia, you are correct. If you got 4 questions correctly, you did a good job. If not, rewind this video to check your answers. This ends the slide set. Please do not forget to subscribe to my YouTube channel, Memory Aid Nursing. Thank you.